We're going to just let everyone get settled. Jeremy, just give me a thumbs up, please, when you think people, oh, we're good? Okay, that was fast. Good morning, everyone. I'm Joey Hessel, and I'm the chair, excuse me, of our Greenwich United Way Community Planning Council, which meets monthly on different topics of concern related to our town. We invite experts in the field to share with us latest data, statistics, trends, patterns, whatever it is that we need to be aware of, in the hopes that we can better understand the issues at the core issues and try to figure out as a community how we can solve them. I'm also a board member of the Greenwich United Way, and I thank Jeremy and Rob, who are amazing staff members, for helping us do this morning. And David Rabin, our CEO, is not able to join us, but he is very much in support of this program as well. Just want to remind everyone that we are in fact recording, so that you're aware. And without any further ado, I'd like to welcome our experts. We have Glenn and I said it right the first time. Let me see if I do it again. Clarena, right? Okay, yeah, and Rebecca right here. And thank you so much for joining us from your various locations. The topic today is child and adolescent mental health, part 2. And we have gathered together. This is obviously has been a topic of concern for a long time, probably since the creation of teenagers and adolescents, but I think more so now than ever due to the pandemic and social media and all of these lovely other inventions in our lives. So without any further ado, what I'd like to do is just ask each of you to introduce yourselves and your role in organization, what the mission is, what you do there. So who's my most extroverted speaker today, or the most caffeinated?
I'll go. I'm on great. My 5th carafe of coffee. My name is Clarena Macbeth. As Joey said, I am a licensed mental health counselor and a licensed professional counselor, which essentially mean the same thing, just in 2 different states. I have been in private practice now, I guess almost 11 years, and I've been in the field probably more like 14 or so. I started working in Manhattan out of grad school and worked mostly with adults for some time, specifically with adult males doing group therapy with sex offenders. And then later I transitioned in working with juvenile delinquents at a nonprofit organization. And then later when I got married and moved to Greenwich, I started a private practice here. And I've been seeing, I guess it really runs the gamut. I see all ages, but mostly adolescents and young adults. That's sort of like my sweet spot. I see a lot of anxiety, depression, eating disorders, adjustment disorders, just some more severe than others, and some very just general stress-related issues. What else? I forgot your question.
I think that's
yeah, that's pretty much it. I mean, my mission, I think, and not to sound totally weird and cheesy and religious, but I think it's just what I was called to do. To help others and to help them find a better quality of life and to understand themselves and their minds and the people around them a little bit better. That's been my goal and my mission, and it's rewarding some days more than others, but generally that's what I do.
I have so many questions for you, but I guess we'll have to meet offline for those.
Sure.
And not to worry about sounding religious. You've got a rabbi here, and I see a pastor, so you're in good company. You're with professional people. But thank you for being here, and more importantly, thank you for being a part of the community. We're so lucky to have you in our midst. Glenn, would you like to?
Sure. And I just want to apologize with the stripes on my face. I have my blinds down, but the sun is strong, which is a nice thing to have. So hi, everybody. Good morning. My name is Glenn Wolf. I'm a licensed clinical social worker. Obtained my Master of Social Work at NYU some years ago. I work at Greenwich Hospital in our outpatient psychiatry department, providing therapy to adults and running from 20 up to 90. I do maintain a private practice in the area, seeing adolescents and family work and adults. I like working with men at midlife who, sort of questioning their identity of who they are, if they're changing jobs. A lot of people have been unemployed, so things like that. I like Clarina. I have an absolute passion for what I do. It's, again, a calling. It's so gratifying and rewarding to be part of a journey that people are on, and they're suffering and changes in their life. And I come to work, and it's a joy to be here. And so I'm glad that you welcomed me, and I look forward to talking more this morning about what I do.
Great, and we will return back to you quickly, Glenn, because we know your time is limited, and we appreciate the time you gave to us today. Rebecca, please share with us.
Hi, good morning. My name is Rebecca Campbell. I'm a licensed clinical social worker. And like Glenn, I got my master's degree at NYU. I don't know if we were there at the same time. And then I went to an institute, a psychoanalytic institute in New York City for 3 years, where I was trained psychoanalytically to treat children and adolescents. And then after that, I practiced for a bit. I've been in the school systems out here in Connecticut and Wilton, the high school, Fairfield school districts, and the elementary schools, juggling a private practice at the same time. And then I was hired into an organization, a multidisciplinary center. We have 2 locations, one in Darien and one in Wilton and one in Stamford, called Sasco River Center, where I'm the director of clinical therapy, and I'm also a psychotherapist. And I tend to see kids and adolescents, young adults, and I do a lot of parenting work too. So in a nutshell, that's me and my kind of training, and I'm really glad to be part of this conversation. So thank you for having me. Absolutely.
So without wasting any time, I want to come back to Glenn. As I said, we only have about 20 minutes left with him. So here are a couple of questions for you, and then you could just share. One, and this I'm going to ask for all of you. What was the driving force? 2 of you said that it was a calling. But I guess, what do you think caused that calling, and when were you first aware that this was something, an avenue that you would want to take? And then specific to your particular roles, Glenn, you mentioned you have a private practice, but you also are at Greenwich Hospital in the outpatient section. So I'm curious to hear what a typical day might bring, if there is a typical day, and also perhaps what is different in 2022 versus 2019 in terms of what you're seeing in particular. So please.
Well, I just want to tell you guys a story of Jeremy, a patient that I've seen in the past. So he's a 14-year-old boy, lives with his parents and 10-year-old sister. He's currently in the 9th grade. So with COVID, he missed his 8th grade graduation, missed the graduation parties. His beloved maternal grandmother, died about a year ago. She was 82. And she died of COVID, and she was living with the family, and that just absolutely devastated him. He's been a good student, has lots of friends, active in athletics, and kind of all of a sudden, his functioning just kind of plummeted. And he stopped studying, he missed classes, he stopped going to the track team practices, and again, stopped seeing his friends, isolating. He just went right to his bedroom upon coming home, had dinner in his room, didn't want to join the family, and complained of he had trouble falling asleep, would get up in the middle of the night, and he was having really bad dreams involving his grandmother and his parents, and whether the parents would also get it, whether he would get it. Outside the dreams, he was worried that he might give it to his friends. So there's a lot of uncertainty, a lot of upheaval and upset. And I got a call from his mom, very upset. She'd heard about me from the community, asking for help. So what I usually do with adolescents is I first see the parents without the child, and just to get a history of the family, whether any family history of depression and anxiety, and early childhood history of Jeremy. I do that, and then I meet the next session with the parents and the child. So I met with Jeremy and his parents, just to get a feel of the dynamics within the family unit. And then most importantly, I met with Jeremy. And with adolescents, it's harder to kind of, you're sitting across from the child, and adolescents are like, oh, I don't want to be here. My mom, forced me to come. So I approach adolescents differently. I come from a place of course, compassion and empathy for what Jeremy has been through. And I listen a lot, and I'm curious and attentive and interested in the adolescent's life. And that to me is most important, because this is a place where, wow, I can feel safe, and I can be myself with a therapist, with a person like myself, with no judgment. And I'm here just for him. So, so with Jeremy, I just, asked, like, what kind of things do you like to do? What activities do you like? Do you have a best friend? Just to get a sense of his life. And then gradually building that therapeutic alliance and rapport, we go a little bit deeper in what's been happening with you, Jeremy. I understand that you're not doing your homework, you've been isolating. So how can we go on this journey together? And so it was really rewarding. I do, like Rebecca, I do parenting work. So I would meet with Jeremy's parents once every 3 weeks, so once a month, and guide them through this uncertainty and normalize their experience of an adolescent, 14, 15 years old. My goodness, all the hormonal changes, societal changes, psychological development, and then just continue with Jeremy and come up with coping skills. So adaptive coping skills, because the way he's been coping has not been adaptive, obviously.
Can you give us an example of what one of those would be?
Sure. So I for myself, employ mindfulness. Mm-hmm. So it's really being in the moment and talking about things that he can control versus the things that he can't. And during COVID, of course, and still, there's so many uncertainties. And so we, he was nervous about mask wearing and other people not wearing masks. And so we said, only you can control what you can do for yourself. You can't control the other person not wearing a mask. You can wear a mask and maintain the personal distancing. And back to the mindfulness, it's practice meditation. I advise patients to use two apps, Calm, C-A-L-M, and also Headspace. And that slowly teaches the person of really how to stay in the moment. I also ask, I asked Jeremy, what are you grateful for? And that to me grounds the person in the here and now. And he said, gee, I'm grateful for my parents. They, this has been a lot for them. And I know my mom's mom died and it must be so hard for her. So even though I don't like my sister, I'm grateful for her. And I do have a dog. Jeremy has a dog, and grateful for the dog, who provides a lot of love and unconditional love and companionship. And just, he said, and this is so profound, he said, I'm just grateful for my life. And I also want to install a sense of hope. And I do say, so what are you hopeful for? So Jeremy said, I do have some hope, but I just a little bit uncertain about this. And I say, if you can hold on to that glimmer of hope, that'll get you far. And I'm here, Jeremy, to help you through that and help you to really gain a full sense of hope. So again, I just love my work, and it's so exciting to see that changes. And I've seen some changes in Jeremy, and we will continue to work together and attach ourselves to that glimmer of hope.
Thank you for sharing that. And I'm glad to hear that Jeremy is on the path towards healing and good health. Thanks to your guidance, of course. I'm curious to know, in the hospital, how does that work? It's an outpatient, so it's not a lockdown unit. So what is the difference at the hospital versus at your private practice? Are people just walking in, needing help at the hospital versus making an appointment and sort of doing it more formally at the practice?
Yeah, it's a good question. Yeah, so in my prior practice, people do call and set up an appointment like I do with Jeremy and his parents. In the outpatient psychiatry unit, again, it's not an intensive outpatient. So it's an outpatient, so meaning that the individual comes to the hospital through scheduling an appointment, and we do meet. And again, it's probably once a week that I meet with the patient. It's about 45 minutes. And, we just sit down and again, like I described, you talk about their current experiences, some family history, and again, coping skills. So I think that's the main difference. We also have a psychiatrist on staff, and who specializes in treating adolescents and adults. So in this case with Jeremy, he's private, but if I would see a patient here at the hospital and I determine that the patient needs some medications to manage depression, anxiety, I would refer to our psychiatrist here on staff, who would again evaluate the patient and determine if medication is necessary. If so, the psychiatrist does that. and would meet with, at the beginning, probably once every 2 weeks, then once a month, see how stable the patient is, and then going forward, maybe once every 3 months. The psychiatrist and myself, we work together closely as a team. And I do say to the patient that, like, now you're so lucky you have partners and a team here for you. And so again, we talk probably once a week or through email, just to sort of touch base with each other. What's the status on each of our sides with the patient. And so again, with Jeremy, I consulted with an outside psychiatrist, but here at the hospital, that's how it works. And our therapy is more of a brief therapy. So I mean, there are some patients I see for years, but usually it's a brief therapy. So I employ cognitive behavioral therapy, which, you know, a lot of people know about CBT, which focuses again on the here and now and using those coping skills. And, you know, a person will come in with negative thinking and thinking the very worst. And we work on changing that thought pattern to more positive. Again, one of the things I also use is positive affirmations, which are terrific. And again, like saying simply like, I am a worthy person. I love myself. I'm grateful for my dog. You know, things that will really keep the person in the here and now.
So I actually have a question, Glenn, going back to Jeremy, going to his parents. And many of us on screen are certainly parents or adopted parents by other people's kids. What did you tell them, and what might they change within their home or their sort of the homeostasis that exists in that house, the environment? Because I think a lot of times even the best and well-intentioned parents don't realize the messaging that is like the undercurrent messages that are sent out unintentionally or they're unaware of. Were there things that you could tell Jeremy's parents to help the situation as well, and what were they?
Sure. So, you know, one of my roles is a educator. So, you know, I talked with his parents about the typical warning signs, you know, for depression and anxiety, which certainly Jeremy has had. So, you know, I say to them, be aware of changes in Jeremy's behaviors. And I described before, like, you know, missing classes, not eating with the family, Jeremy talking about, oh, I had this terrible nightmare. To be aware of why Jeremy has frequent outbursts of anger, which, you know, could be, you know, normal for a young adolescent. And anger is usually an outwardly manifestation of depression, really. So teaching them how to manage his angry outbursts and their own, and how to manage their frustration and impatience. I'm a parent of two adolescents myself, and, you know, it's challenging. So I also talked to them about how to talk to Jeremy about mental health. So then the parents educate Jeremy. And so one of the things I say is that when you sit down with him, he'll say, I don't want to talk about this. And just sort of listen and be present, and don't say, oh, this is going to get better, because maybe it's not true right now. So, and so again, allow for that silence and be genuine. And I also find that with Jeremy and his parents, if they're sitting across the dinner table, he's not going to talk because, again, that one-to-one eye contact, it's not going to work. So I say, the best place, I know this from personal experience, the best place is driving in a car, because both of you are looking forward out the window and just kind of shoot the breeze. And or take, his father's taking Jeremy out for just dinner and have a boys' night out, maybe go bowling, taking a walk, practice some baseball in the field, even washing dishes or walking Jeremy's dog. And also don't trivialize their feelings. The feelings are real. He's feeling them. And so again, just kind of be present. And I think that's the way for Jeremy and his parents to kind of become closer to each other. And so that's really my experience.
Thank you for sharing that. And, kudos to Jeremy's parents for being aware enough and in tune with their child to seek help and not have any of the shame or the stigma that sometimes people feel about that. And I'm glad to hear that they're all moving in a forward direction.
Yeah.
I know you have to go, so we want
I
to
do.
thank you for sharing all of that. And we know where you are now. So we hope to see you again soon. So thank you, Glenn.
Thank you for the invitation. And this has been a great morning. Enjoy, everyone. Have a nice weekend.
You too.
You too.
Bye-bye now.
So Clarina and Rebecca, rather than going into specific patient stories, although certainly feel free to share them, I would love to know what you feel are the major differences today versus years ago for adolescents. We know that so many of us are more anxious or more on edge, which is, I was listening to NPR this morning. I don't remember who the guest is, but she wrote a book about how, the rudeness and the short-temperedness of people is a result of COVID and the instability and the uncertainty and all those things. So can you share a little bit more about, what are the patterns that are developing now, now that we've been in this period for a while and we've been able to see it? What have you noticed?
Well, I think what Glenn was touching upon, the kids with during COVID, the isolation, the kind of poor coping skills that they picked up with regarding eating, my patients eating, sleeping, self-care, certainly social media. That's just a hugely different piece to everyone's life, especially adolescents, I have found, and my colleagues have found as well, the reliance on it for stimulation, for gratification, for self-worth, and all that plays a part in one's anxiety and depression. And certainly, I'm sure, Clarina, you would agree, like the numbers, we all have wait lists now, like the people that need mental health, whether or not it's because of the situation that Glenn described, where there was a family member that passed, fears of the future, uncertainty. Our adolescents have only been on this earth for like a decade plus. Their baseline is so much shakier than ours. They don't, adults in their lives were in a state of chaos as well. And adolescents and children look to adults, even as much as an adolescent might think you're embarrassing and disgusting sometimes. They still look to you for stability and try an understanding of what's supposed to happen next, and to keep structure. Structure went out the window. Some families I found did thrive in COVID. It brought them closer together. Most of the people that I have seen, just because, we're in the mental health field, did not, for all these reasons. So I think that those are, again, like just social media and understanding the self really in the context of where these kids are during this stage of separation and individuation, which is the primary developmental task during middle school and adolescence is separating, figuring out who you are, where do I belong, what are my interests, what are my goals, how do I feel about myself? You know, Glenn was describing Jeremy and some of the affirmations. Well, a lot of the kids I see don't like themselves. They don't love themselves. They find it hard to feel good. So a lot of, and you know, as you were saying, you can hear it on NPR and all these people talking about anxiety and depression, but that is just so meaningful and such a testament to how things have shifted so much as the mental health need is just so much greater for these reasons, for these kids.
I guess maybe the silver lining is that the idea of asking for help for mental health reasons is more mainstream and acceptable.
It is. It's not as stigmatized. It's in fact, like a lot of kids, you know, one of my daughters had some friends over and they were all talking about their OCD. Now, not all of them have OCD, but like everybody's just, you know, it's to the negative side to that is that TikTok, everybody's got OCD, everybody's bipolar. They're like pop culture terms now, very gloms on to cutting and eating disorders because it's like the hot topic. It gets them attention, it allows them to connect in ways. And social media is really an experience blocker. You know, it keeps kids tied to this instead of like up and developmentally, socially, when they're supposed to be socializing and growing in this way. And our kids have been isolated, you know, with COVID. But I'll stop talking now and Corinna, go for it.
Yeah, no, I mean, I second everything you said. You've sort of covered all of the bases. I mean, and we might know this already without all of us being in the field, but you know, the fact is that the social media and just the internet in general and what it's created for us in a good way has also created an enormous problem for children and adolescents and teenagers. You know, like Rebecca said before, maybe a parent was afraid of your child, you know, hanging out with the person that was being a bad influence. Now they don't even have to hang out with anybody. They learn all of the disordered thinking and behaviors just by watching something. Like legitimately, you can learn how to cut, you can learn how to develop an eating disorder, you can learn how to do all of those things without ever actually interacting with a human. And that's like a giant layer of problems and concerns, sort of like across the board. So I think that, I mean, and so that's been going on for essentially since social media popped up, right? But it's been exacerbated recently because of the fact that we've been isolated. And, you know, in a lot of ways in the beginning of the pandemic, you didn't know if you got COVID if you just stepped outside your door. I mean, there was that
back when we were wiping our mail.
Correct, right. And, you know, undressing in the garage after you went to the grocery store, like, you know, so that, you know, that's like Rebecca said, children, adolescents, even just adults, you absorb that from one another. And yeah, I think generally speaking, I've heard a lot of people say, and people in my practice, like, oh, you know, we've grown closer together because there weren't activities, and before we were just like in the car driving to and fro all the time. And so I think some of that was positive, but then the other side to it is that then all of a sudden everything opened up. We all remember that, right? One day we were wearing masks and the next day we didn't have to anymore. And so that severe sort of shift, that shift has caused people to, you know, become anxious about being out in the open and,
right, the next
interacting. Correct. So, you know, just repeating myself, but the social media situation has become worse. Every year it's a little more intense. Every year it's a little worse. But since 2019, I think it's mostly been the fact that we've been isolated, and that's been in a lot of ways, the only way we can communicate and maybe even socialize with people that we know, which affects the way adolescents socialize face to face in real life.
Definitely. Thank you for sharing that. And, you know, I think that parents and kids and just every human being obviously had to adapt quickly. And you're right, that juxtaposition between wearing a mask and then the next day at school, you don't have to. There's no transitional time to sort of wade in, you're just jumping. without a true understanding of any of the consequences, positive, negative, or in between. And then also, I think there is a subset of families for whom the anxiety level is still very high because their children are so young, they can't yet have a vaccination if they so choose to do so. So I think that, I remember when my daughter turned 5 and we were like getting the shot and we were so happy, and then I have friends who had 4-year-olds just sort of like waiting around, waiting. And you don't realize, I think, how stressed you are until you pass that benchmark of 5 years old. And all of a sudden you feel a little bit more relaxed and you realize, wow, I was holding a lot just now. And I think that people aren't even yet aware of how much they're holding on to and the trauma that will exist and probably be passed on to future generations, who knows. So I appreciate you sharing that as well. I think there are going to be a lot of studies being done for sure about the impacts of COVID. And the other area I think that we haven't talked about is the changing family structure as a fallout of COVID for those who were not successfully bonded as a family unit, right? There's a lot of divorce, separation, and death, and all sorts of changing, impacting the child and the family structure. So, just another level to keep you in business. Can you share with us psychological testing? Like, okay, I bring a child to you, my child, and she just seems different. I can't put my finger on it, but I know my kid, she's definitely different and not in the best of sense. So what do you do aside from creating like a bond, like Glenn was saying? I mean, what process do you go through with them?
Well, I can say with so at SASCO, we have psychologists and we have a neuropsychologist, and they do psych testing. And when you do psych testing on somebody, you don't actually, you may not, it's not a patient of yours. Like I might have a patient and I might be seeing them for anxiety and depression because they can't concentrate and they have recurring distressing thoughts, and but it's really they're really not concentrating well in school, and they're having to they're not getting their homework done, and they're not sleeping well at night, and maybe math has always been hard. And I think like there might be something else going on there. There might be something learning, might be a cognitive delay of some kind. There maybe it's anxiety. Is it ADHD? Because a lot of times anxiety and ADHD look the same. Maybe it's a mood disorder. If there's a lot of like going from 0 to 60 pretty quickly, depending on the age, then you would take them to a psychologist who is trained to do testing, and they would develop a quick relationship, like, hi, how are you? Meet the parents, get all the historical information about the development, the family. And then they would sit down probably for 3 to 4 sessions, depending on what you're testing for: social, emotional, cognitive, learning. And they would do batteries of tests. And Corinne, I'm not sure if you're familiar with all the testing names. I don't know all the testing names. I'm not a psychologist, but I sit in a lot of these meetings. But a lot of them have to do with manipulating things. If my example, well, are we looking for maybe a math disability? They do special tests to figure out spatial relations, and not necessarily sitting there and doing 1 + 1 = 2, but different kinds of tests that pull for these indicators that would then lead a psychologist to be able to read the results and say, yes, he's a learning disability in math. He also looks like he has ADHD, maybe underlying anxiety as well, to the parents and the child, and then make recommendations, maybe some learning support, an executive functioning coach, perhaps if it was ADHD, maybe medication for the ADHD and the anxiety, and then refer out for therapy. So in my experience, that's how psych testing works. And it's really if your child is having difficulty functioning in some area that is recurring. It's not like, oh, he just got 3 Fs on a math test in a row. Oh, but actually it's because he had the flu and he broke up with his girlfriend. But it has to span a certain period of time. It's also quite expensive. Schools will also proactively do it because schools really care how you perform and they have limited resources. And so they will say, we'll test your child for you. It's not generally as comprehensive as a private organization, but it will only test for school-based disabilities or challenges because as they're impacted in the school community. So I noticed that because I think Robert, I believe that's his name, had asked us to talk about that. So I just had that quick in my head.
Yeah, no, I mean, you covered it. There's many different names to the test that I would have to look at my notes. I don't know them all offhand, but typically it's psychoeducational, which is what you were just talking about predominantly. So there's psychoeducational, and then just general psychological testing, and then neuropsychological testing. That's more for individuals that may have had like a traumatic head injury or things of that nature. Personally, for me, I am not a psychologist, and so I don't do the testing myself. I could do what I normally do is like a preliminary like assessment to get to know the person and get some background information. And then depending on that, if something sticks out, I will then refer for testing if I think that that's necessary. But they come to me after being tested, and then I treat them through psychotherapy. Sometimes though, the psychologist that does the testing can then see the person for psychotherapy. But generally speaking, like Rebecca said, for psychologists that do testing, that's usually just what they do. And they do well doing that. What else? And for the psychological testing, I mean, they're very comprehensive and very broad. So depending on the symptoms that you present, the psychologist really caters to what you're presenting with. So it could really become anything, which I think even though that sounds like it would be a negative thing, it's actually a positive thing.
It's more fluid and they can tailor it.
Right.
So I know that someone mentioned CBT, cognitive behavioral therapy. There's somatic therapy, and what's the one? Names of different therapies. Can you share with us a couple of sort of the more mainstream ones that you employ to help your patients, your clients?
Yeah,
what they are?
Yeah, so I generally treat clients, patients, individuals with CBT, which is cognitive behavioral therapy, or just cognitive therapy or behavioral therapy. Usually talk therapy is my favorite to do. And then depending on what the symptoms are, what the particular problem that they're coming to me with, and we sort of decide where we're going with it. CBT is very popular because it's goal-oriented, it's present, it's active. So it's not just the person talking to me or me talking to the person, but it's really working together to find a solution to their symptoms and how they can move forward. It's short term. So depending on, again, what the person comes to me with, if that's just that one thing that they need to discover and resolve, it's probably the best treatment to go with. Cognitive therapy is very similar, but it more identifies thoughts and negative patterns in thoughts, and then you kind of figure out how to change them. Behavioral therapy is kind of the same, but you discover the negative patterns in the person's behavior. Talk therapy has been very successful for me in terms of seeing change in people. Similar to what Glenn was expressing before with his case study. I think that, I see a lot of that in my practice as well. And sometimes people just need to be heard. I've, through my experience doing therapy, I've discovered that it's really not, it's not a desire issue that people present with. It's really more of a skill set issue.
Mm-hmm.
So even if somebody that should be doing therapy and should be getting help and they're not, it's not because they don't want, it's not because they don't desire the positive change, it's because they're stuck and not knowing that on the other side, there's skills that they can learn to have a better life. So
So you help them with the how.
correct, right? Sort of facilitate the change.
Great. I like that. Facilitate the change. Rebecca, what about any additional
I
things?
don't, I'm trained a little bit differently, but I pepper in some CBT. I generally, especially with adolescents, come from a place of developing like an interpersonal relationship and working on that kind of who they are in their environment, allowing them to set goals. The adolescents that I generally see kind of want to be there, but they're not ready to dive into like, some of them just take a lot longer to warm up. They're coming with pretty acute symptoms, some of them not as much. And there's another, Lauren, I'm sure you're familiar with DBT, dialectical behavioral therapy. It's very much like CBT, except it has a component of mindfulness as one of the primary components. And it talks about being able to tolerate acceptance, like acceptance of a feeling and change. I am feeling depressed, and I'm going to move through this moment by taking a walk right now. And I tend to side on DBT practices more because I feel like there's so much of a deficit out there of distress tolerance and frustration intolerance by people. And the practices that DBT is founded upon kind of resonate more with me. But I tend to kind of meet my client where they're at, and depending on what their needs are. And certainly that child or adolescent does not exist in a silo. We also work with the parents and school people and psychiatrists, or if they're, any other adult that touches their lives, there's a lot of collaboration that goes along with it too.
It's wonderful to know that everything, it takes a village, and all the villagers are in it together.
Mm-hmm.
We are coming to a close. So I wanted to ask just about, you've mentioned cutting. We know that there's a vaping issue, there are drinking abuse, drugs, sexuality, sex, intimacy issues, all these things. Are there any issues, challenges that are coming out in recent years? I feel like each generation sort of has their thing or things more so than other things, and it changes and it cycles and whatever. So what do you see? And maybe you don't see it because you're getting the kids that are getting help, but for the kids that are either self-medicating or seeking unhealthy alternatives to feel better, what are you seeing or hearing that kids are doing, those kids?
It seems like there's just so much more of all of that. Like, I don't know if there's anything new. I see so many kids now that smoking weed is not smelling like anything. I mean, the edibles, the pens, there's so much dependency on, and you don't get caught for drinking and driving when you smoke weed. Like, I just hear so many kids that, and now the potency, the THC levels today are so much higher than when we were younger. And I do want to say one thing. I just feel like, I know we're running out of time, so I'm seeing a lot more of it, but I also wanted just to mention something along those lines. There's been studies that have shown that open lines of communication with the parent are the best mental health predictor. So with all of these things happening, as a parent, understanding that these things are happening, they're out there, and for you to be able to connect with your child before you correct them, I think is going to give you a much better shot of helping your child and developing that relationship and giving your child a sense of agency and choice in their life, and to be able to make those good choices. I just felt like that was really important to mention on this call.
Yes,
but to answer your question, and I'm sure Klarna, you have more to say about this too, like, I'm just finding more of all of that. I don't think there's nothing new that I can think of, but there's just, and especially on the drug and juuling front, it just seems to be really prevalent.
Yeah,
and
there's nothing new. It's what it was before, but just worse. I would say that something that's maybe a tiny bit different is that there's more attention-seeking behavior that's sort of driven by what these children or adolescents or whatever absorbing from TV and social media, that like, you know, you can be famous if you do whatever it is that you're going to do on your face on YouTube or whatever. That's more common and has pretty strong influence on them. But generally speaking, drugs, alcohol, promiscuity, it's all still there.
And I would also add to what Rebecca said about weed being more potent with the THC content. I would imagine that because neighboring states have legalized it, it creates even more of an issue. I mean, I know they're, you know, you probably have to be 18 or something, some age to buy it, but people do. I work in the city half the week, and you know, you can't walk a block without smelling it. So I would imagine that just creates an even more difficult layer for parents and teens, because you're then always around it, like not just at a party.
Well, and they don't find anything wrong with it. See, so they're seeing it out there. It's now medical. So they're like, it helps my anxiety. You know, it's now legalized. So what if my brain's, I'm like 6 years away from 26 at this point. This is like 26 is when your brain is developed. Yeah. But yeah, that's what's, I think, sends a mixed message too, because they don't see the downside to it as much.
Yeah. It's that frontal lobe issue.
Yeah. I mean, you don't even have to smoke it anymore. You just have a gummy, and so many adults are doing that anyway. So it you know, it's just so the message that's being put out there is confusing, very confusing for that age group.
So I wanted to leave just the last couple of minutes to the two of you for any final remarks or, you know, reflections.
Yeah, I mean, I think what you said before, Rebecca, was perfect. I think that having an open line of communication, even when even when you don't want to, and it just feels like the last thing that you ever want to talk to your kid about, or you can't even believe that he or she is coming to you with, you know, whatever it is that they're coming to you with. I think the most important thing is to have an open mind and let them speak before you say, no, go to your room, or, you know, whatever, because what they said was so shocking. I think they need to be able to find confidence in you, in the parent, and that sense of, okay, this might be horrible, but my mom and dad, they're going to hold me down. They're going to listen to what I'm going to say, and you know, we're going to get through this together. If they don't have that with you, you don't want them to have that with a friend, and they spend most of their time with friends. So I think that's a really important piece of advice. I mean, that's probably the most important.
Yeah. And I think being reasonable, like being able to, like Clarina was saying, like hearing your child, you know, you're going to want to put Life 360 on there. I never had to do that with my kids so far. I don't know. But then he never gave me a reason to have to track him, which I just think that, you know, if your child gives you a reason for doing that, that's great. But I think that these kids they track each other now on their snap maps. I mean, everybody's tracking everybody, and everybody can't sneeze without somebody knowing about it. So allowing your child to just move a little bit, you know, watch them and have that open line of communication, set reasonable expectations. I think from what I've found are the best predictors for like healthy development and a healthy relationship with your child.
Thank you so much. I would just add, you know, that you guys take the bulk of this because you have waiting lists and people want to seek out help, which is wonderful. And, you know, one of the things I do is I remind my daughter, we go over, you know, who are the other adults in your life that you can trust with your feelings? You know, your teacher, your pastor, you know, with your drama teacher that you adore, you know, whoever it is, just to remind them that there's not just one person, right? And if at some point when she hates me, which will happen, she'll have some other ideas of who she can go to. Maybe she'll wind up in one of your offices, who knows? But anyway, we all really appreciate this information and your time, especially knowing how busy your days are helping others. So we appreciate your taking this time with us. one of my favorite development theories comes from Eric Erickson. And I just looked it up because I couldn't remember verbatim the quote that I like, but it's life doesn't make any sense without interdependence. We need each other, and the sooner we learn that, the better for us all. So indeed, adolescents are going through an identity versus confusion stage, and thankfully we have people in our community such as you who can help guide the entire family system towards a healthier way of living. So thank you.
My pleasure.
I want to thank Mario, who's the light is behind him, so it's hard to see his face, but he's the chair of our board, for joining us. And he's also a dad, so I'm sure he was writing notes. And we look forward to seeing everyone at our next meeting, which I have down as May 19th. And should anyone wish to get in touch with anyone on here, I'm going to volunteer Jeremy and Rob to be the point people for that. Thank you, everyone. Have a wonderful spring. It actually looks like it's here. And so we will see you next month. Thank you so much.
Thank you.
Thanks for having us.
everyone.
Bye-bye.
Bye, everyone.
Bye.
Bye-bye.